Okay? This lecture is about sepsis. This is a very important pathology for us to recognize. It's really under-recognized in pre-hospital, and we play and are going to play a big part in how these patients are treated. I'm going to start with this horrible slide here talking about macrophages, leukotrienes, proteases, oxidants, leukotriene. Don't worry about that. No test at the end. These are mediators of inflammation. The only reason I put that on there is to say this is what causes the reaction. You don't have to, I just put this on there to kind of get things started. Let's go to a scenario. We all like scenarios. You are dispatched to a long-term nursing facility for a medical illness. Upon arrival, you find Gerald, a 76-year-old male who's a nonverbal and unresponsive patient. Gerald had a stroke 2 years ago and has a feeding tube and indwelling Foley. Nursing states he normally opens his eyes when his name is called. They also state he has a fever of 101 degrees since early this morning. Your partner starts O2 and obtains vital signs. Everybody comfortable with that so far as you approach this? Now you guys are the lead in this scenario. You notice on your preliminary exam that the ostomy site where his feeding tube exits is red and swollen and pus is leaking out of the tube. Does that raise any red flags? That's a red flag. Now that should get your attention, and you've not even gotten your vital signs yet. That should get your attention. This is obviously the kind of scene where you want to suspect and act on what you find. A peek at the Foley catheter collection tube shows a gunky-looking urine with a lot of sediment. The urine in the collection bag is dark. So maybe a little dry. I'm sorry? Well, he's probably got more than that. Now, his vital signs. What do you think his vital signs mean? Do you think they will be? Do you think the pulse will be accelerated? Do you think he'll be tachycardic or bradycardic? That's true. It also depends on how old the patient is. Do older patients, do they have the same kind of cardiac response rate that a younger person would? No. They may be on a beta blocker. Could be. You could have a young person, 28 years old, that's a marathon runner. Do you think his pulse is going to be accelerated if he's under stress? Probably not. So take-home point here, you can't rely totally on your vital signs with this diagnosis. Tachycardia, hypotension do not mean shock, and I will be harping on this throughout the lecture. Respiratory rate, it could be elevated. It could be not elevated. It could be just about ready to crash. You can find these patients at any spectrum of the disease. So your vital signs in and of itself aren't going to help you. And we'll see the cases at the end of this presentation show basically patients with pretty normal vital signs and pretty normal presentations, but you have to dig further than the vital signs. That's the catch-all of this diagnosis. Same thing with high blood pressure. You may be hypertensive, you may be hypotensive. Your O2 saturation may be normal, you may be hypoxic. We don't know. And it'll become clear as we go through this lecture why that's the case. Before going further, let's consider a couple of things. Let's discuss the definition of sepsis and shock. We're going to briefly discuss the types of shock, the pathophysiology, the SIRS criteria. We're going to be spending a lot of time with this because you see that's right in the center of your protocol. It's very important and elementary to us making the right diagnosis. The SOFA score, I'm only going to mention that because that's a new way of quantitating and defining septic shock, but that's more of a tool for in-hospital, intensive care unit, and academic research centers. It's not really something we're going to be using either in the ED or in a truck. Why do we care about sepsis? Well, today there are greater than 750,000 cases of severe sepsis a year in the United States. And we project that this is only going to increase by about 1.5% a year. So as time goes on, we're going to have more cases of sepsis, not less. It's one of the big reasons pre-hospital is going to take a major role in this. Compared to other diseases, sepsis is very common. There's AIDS, colon cancer, breast cancer, congestive heart failure, pretty common diagnosis, as our community paramedics would tell us. But look how many cases of severe sepsis we have out of per 100,000. Look at the mortality rate here, severe sepsis. AIDS, not too much. Breast cancer, it has a mortality. Acute myocardial infarction has a high mortality, but so does severe sepsis. That's pretty impressive. And we can interact with this early in the pre-hospital environment, just like we can with heart attacks, congestive failure, trauma. We're going to play a big part in this. Why sepsis? Look at these are ages. People 65 and over. I hate to say that I'm in that category now. People under 65, all ages. Look at septicemia or sepsis hospitalizations versus other hospitalizations. It's a big cause of ending up in the hospital, isn't it? Why sepsis? It's common and increasing in frequency as the population ages. It's associated with high risk of death and long length of stay. Translate that as money, dollar signs, cost of care. It's expensive, and we can make a difference. That's the big point of this lecture and the big point of our protocol. We can make a real difference with this illness. Look at sepsis mortality change with more aggressive treatment, and these are combined from several different studies, that as these hospitals have increased their aggressive treatment of sepsis, and we'll talk about what that treatment is, as you get more aggressive, the mortality decreases. So we know that being aggressive early, giving our fluids, making the diagnosis, getting them to an appropriate facility quickly, and once they're in the ED, getting pressure started quickly, this helps a lot with the mortality. Recognizing this early before it advances is key to beating this. What is sepsis? Let's give a definition. Sepsis is a life-threatening condition that arises when the body's response to infection injures its own tissues. Let me restate that again. Read it with me, if you would. It's a life-threatening condition that arises when the body's response to infection injures its own tissues and organs. So we have a situation here where we have an infection, and we have a septic process going on before any vital signs are really altered or much of anything that we can really tell clinically. We have a process going on which can and does injure the body's tissues, and that's what sepsis is. It's this reaction. We'll be going over this again. We can see the mediators of inflammation. Those are the things I showed you on the first slide with the leukotrienes and all those different things. Long story short is they are released when you have this reaction, and that causes the blood vessels to leak fluid. And if they leak fluid into the third space, you don't have it to circulate. And then your tissues, and this all operates in a hypoxic environment due to the sepsis and the infection. And we'll clarify that. You can also affect your coagulation system, and some people do get into a DIC with severe septic shock. So sepsis and septic shock, we have infection. We have to have infection for this to start. Then we have an excessive host response, is what I just talked about. This release of all these bad actors in the cells are leaked into the system, causing vascular permeability. You get a problem. You get these factors lead to cellular damage, because if you don't have fluid and oxygen going to your tissues, what happens? They don't do well. They will go from aerobic metabolism to anaerobic metabolism to death eventually. You get organ damage. That's how you get organ damage, and you will have death of the cells, of the organ, and eventually the patient. So we've got to try to, we're probably not going to get the patients here. You don't call 911 for a little tissue infection or an infected toe in a diabetic. And you probably won't get them with an excessive host response. Jason had a case, and we'll be talking about that, where this case was about right there, that is very hard to pick up. Most of the time you're going to pick these up. These patients will have evidence of advanced sepsis already. It's mostly where you're going to get these people. So severe sepsis causes poor organ perfusion due to insufficient blood flow, and this can be evidenced by low blood pressure, altered alertness, poor capillary refill, high blood lactate level. Remember lactate because that's key here. Low urine output. Any and or all of these things may be present. If you get it early, none of them may be present. So it depends on where in the pathological process you find the patient. I'm going to regress just for a minute to define shock, because the end product of sepsis is septic shock and death. So let's hold every thought for a minute and let's go back to shock. This is back to school, back to what you learned in ACLS. Remember that shock is any abnormality in the cardiovascular system that results in inadequate organ perfusion. Remember that. That's the key right here. Inadequate organ perfusion. If your organs aren't being perfused for whatever reason, you're in a shock state. Dr. McCaskill did a great job at putting this slide together. I don't know how he did it, but he simplified it better than any diagram I've ever seen. This is aerobic metabolism. This is anaerobic metabolism. Normally, when our body's working normally, we have oxygen present, we have good perfusion, we burn glucose, we get that goes into the Krebs citric acid cycle. You get energy. We get about 34 molecules of ATP here, and you release carbon dioxide. You have a normal pH and a normal end-tidal CO2. Now, I heard in the last lecture you're talking about end-tidal CO2. It was very important. End-tidal CO2 is equally important with sepsis, but for a very different reason. But you'll be using that a lot. If you go to anaerobic metabolism, you'll notice that the perfusion is poor. There's low oxygen delivery to the tissues. You have LDH, which becomes lactic acid. That accumulates in your body, and you can measure that. You can measure it as lactate. You have a very small amount of energy released, maybe 2 molecules of ATP. So it's a very inefficient way of getting energy, but if you're out of air and out of blood, the tissues do this before they will die. And we'll be visiting this again. So septic shock is poor organ perfusion that is due to sepsis that does not improve after reasonable amounts of intravenous fluids are given, usually 2 liters. So the difference between sepsis is you may not be in a total shock state yet, but you're working toward it. By the time you're in septic shock, you will require at least 2 liters of fluid, and your patient probably is not going to respond. Then what are you going to do? Call me? Might. Step on the gas? Probably. Call the hospital or your destination hospital? Maybe you should, because you've got a septic emergency here. But we'll talk more about that. The types of shock, as we know, are hypovolemic, neurogenic, cardiogenic, obstructive, septic, anaphylactic. We're not going to spend time on that because you should know this already. If you take an ACLS, most of you have the hypovolemic, cardiogenic, extracardiac, obstructive, and the distributive type of shock. Septic shock would be a distributive type of shock where you have decreased myocardial depression with depressed systolic and diastolic function, causing diminished cardiac output, diminished mean arterial pressure, and end organ dysfunction, which is the end result of all this. Is this kind of making sense to everybody? One last formula, pathophysiology of shock, cardiac output. Cardiac output is equal to heart rate versus stroke volume. And it's important to understand this relationship because this explains why the patient you pick up may not have an altered blood pressure or an altered pulse rate. So understand that cardiac output is heart rate, how many beats per minute, times stroke volume, how much volume you're pumping with each pump of the heart. This is important because some patients don't become hypotensive, some don't become tachycardic, and some have normal vital signs. Why is that? Let's talk about Gerald again. Gerald, does Gerald have to be hypotensive to be in shock? No. Does he have to be tachycardic to be in shock? Not what we've learned so far. He can have normal vital signs and be in shock, can't he? Remember, shock is not defined as tachycardia or hypotension. It's defined as inadequate organ perfusion. Take home point. Yeah, you are behind. Kelly's absolutely right. By the time you are tachycardic and hypotensive, you are really behind the 8 ball, and you've got some catching up to do. Do not equate blood pressure with cardiac output. Do not equate low blood pressure with shock. We often think, well, the patient's hypotensive, they're in shock. Well, they were probably in shock long before they were hypotensive. That's what you need to understand. SIRS. Okay, we keep talking about SIRS. What is this? Is it what we say here in the South? Absolutely. Is it 2 or more gentlemen? I guess if you have 3 people, you'd call them SIRS, wouldn't you? And if 2 people are holding me at a gunpoint, yeah, I'm going to call them both SIRS. Absolutely. No question about it. Feeble attempt at comedy. SIRS stands for Systemic Inflammatory Response Syndrome. What does that mean? The SIRS is one of the body's responses to either infection or inflammation or other stress. So it's not a mutually exclusive thing with sepsis. I'll show you a big diagram in a minute that's going to make this, drive this point home. The thing that we need to know, if you go back to your protocol and look at the Systemic Inflammatory Response Syndrome, you'll see the temperature greater than 38 degrees centigrade or 100.4 Fahrenheit. Temperature less than 96 point, our protocol says 96.0 Fahrenheit. Respiratory rate greater than 20, heart rate greater than 90, end-tidal CO2, imagine that, less than 25. Lactate greater than 4. If you have any of these criteria plus an infection, then we need to get busy. We need to let our receiving hospital know that we've got a problem. This is the diagram I was talking about. We can see that people, these are all the people that have infection. Well, many people that have infection never get sepsis and never get severe sepsis. And many of them never get these SIRS criteria. But many of them do. By the same token, other things like pancreatitis and trauma, burns, can cause this SIRS symptom complex to appear. But when you couple the SIRS with the infection, then you get a big area here that is sepsis. Is that clear to everybody? And you get a severe sepsis many times, depending on where they are in their evolution, how much time has gone by since this process has started. Does everybody understand that? Okay. So SIRS is a commonly used screening tool in the emergency department to identify the patients with severe risk. These criteria have not been validated, however, in this setting, meaning that the research people haven't done a lot of validation. These criteria are being phased out. Now, why am I telling you something that's going to be old? Because, yeah, they're going to be phased out, but we're going to be using them because they really work. The ER docs and the American College of Emergency Physicians feels that for the next several years, we're going to be using this criteria. There's always somebody in every crowd that said, well, in the February 2016 Journal of the American Medical Association, we see that they are going to have this SOFA score and other means of defining septic shock. Well, that's true. That's an academic tool, but it really doesn't apply to what we're going to be doing. So, yeah, I mentioned it, but it's not something we really need to spend any time on. So here's how this works. If you have sepsis, you have a SIRS criteria plus a suspected or confirmed infection. That's what the protocol's showing. If you have severe sepsis, which remember that was the smaller circle, you have sepsis plus at least one sign of organ hypoperfusion or dysfunction. That's the difference. And that's the difference between sepsis and severe sepsis. And we like to keep our patients from getting to severe sepsis. We don't always have that luxury. So severe sepsis may cause hypoxia and or inadequate organ perfusion, resulting in metabolic acidosis marked by elevated lactate. Here's this lactate again I keep talking about. So it causes elevated lactate and decreased end-tidal CO2 levels measured by capnography. Well, imagine that. We were just talking about capnography. So if we have septic shock, severe sepsis plus one of the following conditions, mean arterial pressure less than 60 or 80 if previous hypertension, after adequate fluid resuscitation. If you need pressors, if you have a lactate greater than 4 or a low end-tidal CO2, you are in septic shock by definition. And if you have a lactate greater than 4, you have about a 27% chance of dying with this. That's not good odds. Let's talk about cellular metabolism. How does end-tidal CO2 fit in here? Because I know what everybody's thinking. Okay, I know enough about metabolism to know that if you don't have good metabolism and you accumulate lactic acid, lactate in your body, your blood is going to be acidotic. And that's true. You'll have a metabolic acidosis, no question. But what's your body's response to acidosis? You breathe fast, you hyperventilate to try to blow the seat, to often try to lower it. That's how you react. So you would think you would be blowing off a lot of CO2, but you're not, because you're in a shock state and you can't get enough blood return to the lungs to give you enough CO2 to blow off to begin with. So you end up with a low CO2, but you're breathing hard. If you understand that difference, and I'll explain that again. Here's aerobic metabolism. Again, this produces 34 ATPs from energy. It's the normal way we use oxygen with good perfusion, and we have normal pH with good end-tidal CO2. If we go to anaerobic metabolism, you have poor perfusion, like we said before, low oxygen to the tissues, LDH converted to lactic acid. We have an acidotic blood, but a low end-tidal CO2. I just put this in here as a definition for you to read. This basically verbally states just what I've said, so I'm not going to spend any time with it. It's there. You can read over it at your leisure. Or if you want to explain it to somebody you're precepting. So, again, I said the anaerobic or the glycolytic pathway, you only get 2 ATPs. Very inefficient for getting your ATP and your energy, whereas your Krebs cycle is very efficient. We don't want to be up here because this causes lactate to be produced. Capnography, end-tidal CO2, is well known to us in EMS. It's a continuous variable determined by basal metabolic rate, cardiac output, and ventilation. Well, there's cardiac output again, ventilation. These are all things that we know about. How does this fit together? Abnormal levels reflect a derangement in the perfusion, metabolism, and/or gas exchange. So anytime we have this end-tidal CO2 is altered, we know that something's going on. We know that from our cardiac arrest all the time, don't we? You may end up seeing, when you get return of spontaneous circulation, don't you see that CO2 come up? Because your body's pumped, you're starting to get circulation, you're starting to get back into the aerobic metabolism, and you'll see that CO2 come up before you get ROSC. In severe sepsis, which is characterized by poor perfusion, this leads to a buildup of lactate, serum lactate, and a metabolic acidosis. So why is the end-tidal CO2 low? And I just told you why, but let's go over this again. To compensate for metabolic acidosis, patients increase their minute ventilation. They blow off carbon dioxide. This lowers your end-tidal CO2. At the same time, poor tissue perfusion decreases the amount of blood flow to the alveoli of the lungs, reducing the amount of carbon dioxide that can be exhaled because you're not getting it back to begin with. Does that make sense to everybody? Got it? So remember that lactate and end-tidal CO2, we can measure both of these in the ambulance. Lactate, we have a little glucometer device that we can use to measure this, and end-tidal CO2, we already have that. I believe there's some reason, I don't know, Billy knows the reason more than I do, about certification that we can't get that lactate measure right now. I'm not sure what that is, Billy.
FDA approval of that smallest unit is in the design program.
Okay. yet. So hopefully we get an FDA approval, we can do that. But that would be nice to have. It would be really nice for you all to have. So remember that lactate's a marker for cellular hypoxia. If you see elevated lactate, you have cellular hypoxia. Based on everything we learned about them and everything we reviewed about the anaerobic and anaerobic pathways. If you have a lactate greater than 4, you have a 27% mortality. If you have a lactate 2.5 to 4, 7% mortality. Less than 2.5, you have less than 5% mortality. So we really want to get our people taken care of before we get to 4, don't we? That's really important. It's really important for the ER docs to know that. And it's going to be important in EMS because it's only a matter of time till we're measuring this in the field. 0. 0, yeah, you shouldn't have any. But if you convert to any kind of, like you put me on a treadmill for a half hour, yeah, I'm going to have lactic acid or lift weights because some of that metabolism will be anaerobic. If you're in perfect aerobic metabolism, you shouldn't have any lactate. So, what a lactate with that? Lactate is the metabolic end product of anaerobic glycolysis, like I said, as the body attempts to generate ATP in an environment of hypoxia. This is ad nauseum. We've said enough of this already. It's also elevated by the body's stress response. So the body attempts to increase glycolysis via the stimulation of beta-adrenergic receptors, particularly in the skeletal muscle by circulating adrenaline. Okay, this is important because this is why many of your sepsis patients who are stressed out and in shock are normotensive. Lactate is a marker of endogenous catecholamine release. So if you have lactate, not only do you have hypoxia, but you're pumping adrenaline somewhere in your body. And you're maintaining your pressure by means of this. That's why these patients are normotensive when you pick them up. They may be maintaining their blood pressure due to a vigorous endogenous catecholamine response. Now we know that your body has so much epinephrine in it, and when it's exhausted, it's gone. And then what happens? Where's your pressure go? Right off the edge of the table, just like a child. It's the same thing, same physiology in a kid. We know that they just crash quickly. These people will crash quickly, and we'll give you a couple examples of that in the cases that I'll be presenting. Does everybody understand that? Because that's important. That's why you can't rely on your blood pressure and your pulse. You have to think beyond it. You have to think outside that box. We're used to just seeing vital signs and reacting to the vital signs. But if there's just a little alteration, there's a little infection, and they're old or they're immune compromised, we've got to go further. You've got to go deeper. And that's where this service criteria all comes in. These septic patients have deceptively reassuring vital signs, masking the fact that they are in catecholamine-dependent state shock, and they're using their own catecholamines instead of running a Levofed drip on them. Elevated lactate identifies these patients as having an increased risk of death or decompensation, thus requiring more aggressive management. Again, I'm going to put these up here again, just because these figures are very striking. 27% mortality if the lactate's over 4, 7% between 2.5 and 4, and less than 5% if it's less than 2.5. An initial lactate level is useful in the ED because it demonstrates the patient's level prior to fluid resuscitation. So if you can get a lactate in the truck when you pick them up and you're halfway to the hospital and you think, well, boy, I'd like to have a lactate level, that's really important because the doctor that's in the ED will know what the baseline was when you picked him up, and maybe he doesn't get, maybe he's got other things to do, doesn't get to this patient for an hour to order another lactate. He can see that difference, and that will tell him, because if this is increasing, then he's behind the 8 ball. So it's very, very important. That's a little meter that Billy was talking about, and hopefully we can be able to secure these fairly soon. Remember that lactate and end-tidal CO2 are inversely proportional to each other. So as lactate levels rise in septic patients, end-tidal CO2 drops. Now, we've already discussed the pathophysiology of why that happens. Just remember that. The lactate's high, your end-tidal CO2 is low. And if you see that, what are you going to do? You're going to get busy, because these people need fluid, they may need pressors, you need to make the proper phone calls to the emergency room where you're going. So what can we do in EMS? Let's see. This is just a summary of trials in here to show that hospitals that have done various different things for screening for sepsis have markedly decreased mortality by interacting early. That's all this says. What are we doing at our hospital here at Johnson Health, both Clayton and here in Smithfield? Yeah, we have a protocol and we have a screening tool. The nurses have a screening tool now, very similar to what our protocol is. You got our respiratory rate greater than 20, altered mental status, blood pressure less than 90, heart rate greater than 90, white count less than 4, greater than 12,000, temperature less than 96, greater than 100.4, PCO2 32. Guess what? Lactic acid's here too, greater than 2. It's the same thing. They're doing the same thing in the ED that we're going to be doing in pre-hospital. And the source of infection, obviously. This is just a sepsis checklist that if they suspect this, they automatically go to this checklist and they start. It's not important that we understand it because we're not working in hospitals, but that's they're all over this. Identify sepsis early as possible. Vital signs, mental status, end-tidal CO2, and fluid resuscitation. That's what we can do. That's what we will be doing. That's what our protocol is all about. Our goals are to give resuscitation starting at 20 cc's per kilogram, but we may have to go higher. And if we have to, we're going to require pressors. Now, by the time you get realistically, wherever your destination, you get this done, you're working in the back of the truck, getting your fluids, you know, make 2 or 3 500 cc boluses. Probably not going to be hanging pressors unless these people really crash. But that's, I think that's just the reality of what we're going to do, and that's why it's not in the protocol. Let's review everything. Fever, increased heart rate, increased breathing rate, confusion, diminished capillary refill can mean sepsis. Think of these, because more often than not you will have these symptoms, but not always. Gerald didn't have them. Older people may not have them. Beta blockers may not have them. Your competitive runners, athletes, may not have this. And anybody, as we saw from the literature, anybody can get septic. You have an infection, anybody can get this. Doesn't matter whether you're healthy or unhealthy. Some more symptoms: capillary refill greater than 3 seconds, urinary output less than 0.5 cc's per kilogram per hour, lactate greater than 2, altered mental status, an abnormal EEG. Well, you won't be doing that in your truck, and you won't be treating or diagnosing DIC either. Remember, if you have an immune-compromised patient, patients that have had chemotherapy, they have cancer, you know they've had radiation and/or chemotherapy, they have AIDS, or some kind of immunosuppressive myeloproliferative disorder, something like that. They have a weakened immune system, and they may not show you any symptoms. Same way with extremes of age. They're very young and they're very old. We know this. They are harder to diagnose because they don't obey the rules. And the body temperature may be low, may be high, may be normal. So let's review this. Systemic inflammatory response syndrome, SIRS. Temperature greater than 38 or less than 36 centigrade, heart rate 90, respiratory rate greater than 20, CO2 less than 32, white blood cell count greater than 12,000 or less than 4 with increased BNs. Now, you won't be doing all this, obviously. These are hospital criteria. You have the SIRS response, severe sepsis. You have the SIRS plus organ dysfunction, hypoperfusion, hypotension, acute lung injury, encephalopathy, acute kidney injury, coagulopathy. Any or all of those are problems in severe sepsis. And then septic shock means basically when you have hypotension, you've given the fluid, and you can't get the pressure up despite restoring volume. This is not like car wreck where you have a bleed and you can give them 2 liters of fluid and their pressure will come up and their pulse rate will slow down. This is, if you're far down the road in septic shock, that's not going to work. I like this slide. I think it's a continuation. It really tells you what the pathological process is and where we have to intervene. We know that we have the SIRS criteria, which we can get from infection, but also from stress, from burns, things like that. Couple that with an infection, so you have a SIRS plus infection, then that gives you sepsis, because you have to have an infection to have sepsis. And then it becomes severe and you get end organ damage because you have all your vessels leaking because of those inflammatory mediators. And eventually you have hypotension because you're no longer going to maintain your blood pressure because you're out of epinephrine and your tissues are starting to really get anoxic. The take-home points, SIRS we discussed, shock is inadequate organ perfusion. Do not equate blood pressure with cardiac output. The SOFA, forget that. I shouldn't even have that in there. Let's do some case reports and then we can wrap this up pretty quickly. And basically, this lady was picked up at 1444, the blood pressure 137 or 84, pulse 79, respiratory rate was 14, her oxygenation, SpO2 was 89. They noticed a Glasgow coma score of around 12, which didn't alter. Blood pressure later on, after they gave her some oxygen, was 151/81. Pulse of 64, respiratory rate is 16, pulse was now 95. And the rest of these, her pressure comes down, then it's up again. But basically, she looks pretty stable. Is anybody bothered by those vital signs just on the basis of looking at them? No. History was kind of vague. I guess the skin was dry, and they noticed that she had some tenting of the skin. There was poor turgor. The mucous membranes were, however, moist. So what's going on with this lady? She didn't feel well. She wasn't quite making great sense, I guess, Jason, but she was not doing badly at all. So they say in their report, they noticed that the radial pulses were okay. Didn't check capillary refill, but particularly no reason to do that because the vitals look pretty good. Neurologically, the patient was weak and unable to walk without assistance, but she had some underlying other problems. And then we found out subsequently that this lady has had some heart failure and decided that she had some swelling in her ankle, so she thought she'd double up on her Lasix. Well, guess what that did? Took a lot of fluid out of her, made her dehydrated. She looks like a prune, and sets her up for other stuff. So upon arrival to the patient's side, ALS assessment was initiated. Medic 1 was already on the scene. Noted the patient has poor skin turgor and decreased PO intake for several days, and the Lasix helped out also. Initial sat of 89 came up. Oxygen improved that. Further assessment. Patient states she generally feels well. However, today she feels weak and not as well. Decreased intake with nausea, no vomiting, denies complaints at present. Tongue was moist, skin with turgor, showed tenting and prolonged rise, which is going to indicate some dehydration. She was assisted to the stretcher, placed in the ambulance, secured, saline lock started, finally got one started. No bolus was given due to the history of CHF. The patient was normotensive, increased blood pressure, and there was no change in her mental status. It hadn't deteriorated. Oxygen therapy was continued. She remained in good oxygenation and went to Johnson Memorial and turned over to Dr. Guha and a nurse. Well, about 20 minutes after that, this patient crashed, didn't she, Jason? I mean, crashed, big time. I'm not going to get into what they did in the ER. They found her blood CO2 was like in the hundreds. I mean, she was in severe respiratory failure. She was in this compensated state that I was just talking about, pumping her own adrenaline, doing this, doing everything, hiding the vital signs. And here she comes in 20 minutes and she crashes. It could have just as easily happened on the way to the hospital or in her house. It just didn't. So you've got to be prepared for this. She had acute acute and chronic hypercapnic, hypoxic respiratory failure, secondary pneumonia, COPD, had a tracheostomy, long hospital course, but she had septic shock. She went all the way from septic shock. That's what she did. She went right off the table from this infection, had this unrecognized pneumonia going on, which you may or may not even pick up on physical exam, because if they're really dry, you're not going to hear those riles. Give them 2 liters of fluid, go back and listen 2 hours later, you hear pneumonia. You'll see an infiltrate that you didn't see before because they're hydrated now. That's, you can get in EMS, you don't have these tools. You got to go on your gut. Basically, this is a summary. This discharge summary said that she presented in an acute confusional state. Blood pressure was found to be extremely low, not when they delivered her, but right after she got there. It ended up in the 60s pretty quickly. Multiple boluses of IV fluid, subsequently put on a leather-fed drip, septic shock, and I'm not going to go into the rest of it, but you get the picture. The picture is these people can crash on you quickly. Case in point, right here in our own county. This is a case Dr. McCaskill had at Clayton in the ED at 5:32. The temperature was 99. Systolic blood pressure a little low here, 87. Diastolic a little low. Diastolic remains low toward time later on. This is an 80-year-old female who comes to the emergency room complaining of productive cough with sputum. Also complains of fever, generalized weakness. Symptoms started yesterday and into today. Patient was seen in an urgent care and sent to the ER for further evaluation. Now, how many times do you get called to the ER or get a call to an urgent care to transport somebody? The doctor there just doesn't like the way they look. Happens all the time, doesn't it? Yeah. So the symptoms started yesterday, and complained of fever, denies any exacerbating factors, cough, shortness of breath, anything like that. Constitutionally, she had a fever, had a cough, shortness of breath. Nothing really much on physical exam. Supple, I don't recall anything here. No prenatal, neurologically pretty good. Checked her for stroke, didn't really see anything there. Mood was appropriate, grooming was good. 88-year-old female, here for evaluation, potential pneumonia, has an abnormal vital signs with borderline hypotension, and fluids ordered, placed a continuous cardiac monitor, got a sepsis workup. Somebody was suspicious of somebody. This doctor was very suspicious, because this is the setting where you're going to have it. So if you think about it, do it. If you think about sepsis in this patient, in your mind, go through this protocol, check things, look at it. If you can get a lactate eventually, hopefully we can, that would be a big thing to do. So chest x-ray showed a right upper lobe pneumonia. White count was slightly elevated. Lactic acid was slightly elevated, and they started her on antibiotics. No shock index noted at this time. So she hadn't progressed to shock, so she's somewhere in the probably 2.5 to 4 range, and I think he puts the labs in here. Again, blood sugar's up like we thought. A little dehydrated because her BUN's up. Creatinine, so she's got some renal stuff going on. Her estimated glomerular EGFR is low. Lights don't look too bad. Potassium's a little high. White count's high, but not that high. SGOT, a little low, but look here, the lactate, the big number. What do we say? Anything between 2.5 and 4 has less than a 7% mortality. If you get to 4, it's 27%. So they were on this early as they could have been. This lady came from an urgent care, and she'd only had symptoms for 24 hours. Yet here she is, 88 years old, highly suspicious situation, early sepsis, and that's how that diagnosis was made. How are we going to treat this? I'm not going to use pressors. They didn't need to. It's going to be antibiotics. I think they gave her ceftriaxone. She's going to be in the hospital for a few days, and my guess is that she probably did well. I do not know the outcome of the case. Case 3. We'll start with some vital signs. Again, here we have a pulse, 134, And we see it going down over a period of time, starting at 2135 to 0600 the next morning. The systolic blood pressure is elevated here, and then it normalizes. Well, that gives us a good idea that some kind of intervention was done here that shows this patient's vital signs they ameliorated. So, the patient complained of headache, abdominal pain, right foot swelling, and a bad odor. She's a 27-year-old female, history of diabetes and hypertension, presents to the ED. One-day history of swelling of the right foot and a bad odor coming from the foot. Warmth, tenderness of the right foot. She states she also had a one-day history of bilateral frontal headache, and she said it was a 9/10. Low-grade fever, some abdominal pain, coughing, and had been coughing intermittently for 2 days. She denies any abdominal pain unless she's coughing, and she denies any wheezing, shortness of breath, things like that. She has not had a true fever at home and denies any sore throat. A little bit of congestion. She denied nausea, vomiting, diarrhea, anything else. She states her blood sugars are usually okay in the morning, but in the 130s in the evening. But here she's 255, so she's above where she normally would be. And the rest of her, she had a little runny nose, but nothing else other than what was going on with her foot. And I believe there's nothing really here except the right foot swelling on the right foot up into the ankle, but not the calf. Skin was red, didn't extend to the knee, didn't go to the left leg, didn't go to the left foot. All the joints were normal, and the skin was normal for age, except for the redness. There was a diabetic ulcer on the right foot at the plantar surface of the 4th and 5th metatarsals, which is right here in this part of the foot. So this is a diabetic, probably type 1, my guess, being that young age, with an ulcer on the foot, pain, malodorous stuff coming out of there that if you call at this lady's house to pick her up, you should be very suspicious of something going on. You should be very, even though she looks well, she's totally with it, or she's not altered in any way. So we see her blood sugar is at 230, sodium was a little low, lactate's 2.3. She's on her way already. She's septic already. She's only going to get worse. Remember that continuum that's in your handout. That's where she is. And that's where we're going to be doing this in EMS to try to diagnose these people earlier and make a real difference. And we can see her blood gases. That's really not that important. So basically, the doctor was just stating what her concerns were about this ulcer and swelling and everything. Lactic acid was 2.3, and she just explains why she wanted to treat this patient. They were going to admit her. She couldn't get into Chapel Hill for some reason, and they basically sent her, I guess, to Johnson. I'm not sure where she ended up. But what can we do with this case? Well, we already talked about what we can do in EMS. Give fluids, make that diagnosis, give the information heads up to your destination ED. It's just like when you call a code stroke or a STEMI or a trauma alert. It lets that ER get ready so they can handle things quickly. And that's the interface. That's how this should work. And that's all I have.